بسم الله الرحمن الرحيم ربي اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقه قولي. I'm Dr. Hambacha, PhD Diagnostic Ultrasound Associate Professor. Today we'll discuss about ventricular dysfunction. So, assessment of ventricular function, particularly of the left ventricle, is the most common and the most important application of echocardiography. The presence of left ventricular dysfunction is a reliable prognostic indicator in all forms of cardiac disease. It has important therapeutic implications, and most of the time, clinical management is altered when an abnormality of particular function is detected. Ventricular dysfunction can be classified as left ventricular systolic dysfunction, left ventricular diastolic dysfunction, and right ventricular dysfunction. So in the case of left ventricular systolic dysfunction, here you can see in this image, the left ventricle is dilated, thin-walled, and its contractility, uh, uh, systole is compromised. In the case of left ventricular diastolic dysfunction, you can see in the second image, the left ventricle is smaller in size with thick walls, and its dilatation or diastole is compromised. And in the case of right ventricular dysfunction, we'll discuss in detail. Its systole and diastole is compromised. So some of the normal values to determine left ventricular dysfunction on the basis of indices. First of all, we should know about the normal indices related to the left ventricle. So normal indices of the left ventricular wall thickness and diastole interventricular septum is 6.12, and posterior wall is 6 to 11. But ultimately, you can say both the walls, interventricular septum and posterior, for the sake of simplicity, should be 6 to 12 mm. Similarly, the left ventricular wall excursion and systole, so the interventricular septum excursion are a movement from the normal path or from the straight path. So the distance in between these two horizontal lines is the interventricular septum excursion, and it should be 3 to 8 millimeter. Similarly, the posterior wall excursion, you can see in between these two horizontal lines. This is the excursion or deviation or movement of any structure from its normal level or normal path. So the distance in between these two horizontal lines along the posterior wall in the M mode image, there is the posterior wall thickness, and it should be 9 to 14. So as you can see in these two values, the interventricular septum excursion is lesser than the posterior wall excursion, right? And then a left ventricular internal dimensions that end diastole. And the left ventricular dimension is 24 to 42, and at end diastole, it's 36 to 52. So you know, in diastole, the ventricle is enlarged. That's why its internal dimension is greater, and that is 36 to 52 millimeter. But during systole, both the walls, interventricular septum and posterior wall, come closer to each other, and the interventricular dimension is smaller, and that is 24 to 42 mm. A left ventricular internal volume, if it is measured, so it will be systolic volume will be 35 with 5 ml of standard deviation, and in diastolic volume will be 85 with standard deviation of 15 ml. Fractional shortening is 35 to 45% change in left ventricular the dimension. So this is the percent change in the left ventricular dimension, right? And left ventricular ejection fraction, so that is normally 50 to 75%, and actually this is the percent change in the left ventricular volume. So the fractional shortening and ejection fraction will be calculated from formulas, but most of the echo machine can calculate these parameter by itself. We'll discuss it soon. Echo features of the left ventricular systolic dysfunction, because our main topic is this. So with the M mode at left ventricular level, as we have seen the image, during ventricular systole, the interventricular septum and the left ventricular posterior wall move towards each other, while during diastole, both the walls are moving apart from each other, and this way the interventricular volume and dimension increase and decrease during systole and diastole. But in the case of systolic dysfunction, this movement of the interventricular septum posterior wall towards each other will be compromised, that will be decreased. So reduction in amplitude of the posterior wall and interventricular septum movement as a sign of systolic dysfunction. Left ventricular internal dimension in end diastole and end systole are measured on M-mode tracing in the parasternal lung axis view at the level of the mitral valve leaflet tips. Measurements are taken from the endocardial lining of the interventricular septum from here to that of the posterior wall. It is over here, right? Mm, yeah. Left ventricular dimensions are increased in the presence of left ventricular systolic dysfunction. So again, we know the normal values of the internal dimension of the left ventricle during systole and diastole. So the values should be compared with the normal value, and if it is greater than the normal value, then other parameters should also be evaluated. Then fractional shortening of the left ventricle and systolic dysfunction. So this fractional shortening will be reduced, right? And the fractional shortening can be calculated from the internal ventricular dimension during diastole and internal ventricular dimension during systole, and then the systolic dimension will be subtracted from the diastolic dimension, and then the result will be divided by the diastolic dimension, and actually that will be a shortening in the total dimension, and that value will be multiplied with 100 to get the fractional shortening. So this fractional shortening should be 30 to 45% in normal individual. But in the case of systolic dysfunction, this fractional shortening will be smaller than 30. As you can see in this example of fractional shortening, we have measured, we have taken two value, internal dimension during diastole and internal dimension during systole. And during diastole, it was greater, measuring 5.77, and during systole, it was smaller, 4.17. And the difference between the two is 1.6 out of the total dimension during diastole 5.77, and then it is multiplied with 100, and the fractional shortening we get over here is 27.7%. So this is smaller than 30, but this is actually marginal. If we get such marginal value, then it will be equivocal, and we will have to rely on multiple parameter, not a single one. So the other parameter will also be thoroughly evaluated. Ventricular volume, however, in the presence of regional wall motion abnormality, fractional shortening doesn't reliably reflect the overall left ventricular systolic performance. The normal volume of the left ventricle during end diastole is 85 with 15 ml of standard deviation. A volume greater than 100 ml is indicative of the left ventricular systolic dysfunction due to myocardial disease, for example, cardiomyopathy, myocardial infarction, because of volume overload due to mitral or aortic regurgitation. The left ventricular volume is derived from the cubed equation. This is a simple equation, which means volume is equal to d raised to the power 3, where v is volume and d is diameter. This equation is based on the assumption that left ventricular cavity has ellipsoid in shape, and the length, major axis is twice the minor axis, the diameter. So, but this is not always true. This is true, but not always true. Sometimes it's false. Left ventricular volume by this cubed equation can be is explained in this schematic diagram and can easily be understood. Simulation of the left ventricular cavity as an ellipsoid, major axis L, which is where this one, is twice the minor axis, which is D. So when two D's are combined, so one D is until this, and the other D is this one. So these two D's will be equal to long axis, or the major axis. If the diameter of ventricle is 4.21 centimeter, for example, this diameter of the ventricle is 4.21 centimeter, then according to the cubed equation, we'll cube it, and by solving it with the while passing it through complex mathematical operation, we'll get 74.61 ml volume. So the volume can be calculated from this cubed equation as 74.61. And the left ventricular volume can be calculated with the help of Ticho's equation, and this Ticho's equation is used mostly in the M mode examination. So left ventricular volume derived from the Ticho's equation, you a major, more realistic and accurate measurement as compared to the previous cubed equation. And here the Ticho's equation is volume is equal to 7 by 2.4 plus D multiplied by D square. So D will here be the diameter of the left ventricle, which we calculated with the help of M mode examination. If the diameter of the ventricle is 4.21 centimeter, then the volume is calculated by putting the values in the equation. For example, all these value. D is equal to now 4.21. So the values are put instead of this D and this D. So if you put values with the place of both the D's, then we'll get value volume of the left ventricle as 81.17. So this is calculated by a Tichols equation. Now here, and these images, you can see the different values have been given. If you want to calculate, this is an M mode image. So the interventricular septal dimension as measured than left ventricular internal dimension during diastole is calculated at 4.83 centimeter. Left ventricular posterior wall and dimension and diastole 1.37 centimeter. Interventricular septum and systole, and then left ventricular dimension systole. So here you can see the systolic dimension, internal dimension, and systole. This is internal dimension and diastole. So this is 4.83 during diastole, and during systole it is 4.12. So the difference is due to the contraction of the heart. Apart from that, interventricular septum during diastoles were here and during systoles were here. So during systole it will be a little bit thicker, which is 16.3 millimeter, as compared to the diastolic thickness of the interventricular septum, which is 15.3 millimeter. So this is the difference which occurs with the contraction of the cardiac muscle. With the contraction, the thickness of the muscle is increased, and resultantly, the posterior wall and the interventricular septum thickness will be greater during systole as compared to diastole. But now we got left ventricular internal dimension during diastole, which is 4.83, and internal dimension during systole, which is 4.12, and the end diastolic volume is calculated 1.9, and in systolic volume is calculated 75.1 ml. So both the volume, diastolic volume and systolic volume, are calculated by the Tichols equation automatically. But if you put all these values in these equations, you will get these two volumes, like this one and this one, and as a result we'll see the ejection fraction as well. So the ejection fraction will be calculated from both the systolic and diastolic volume. So this ejection fraction can be calculated by 109 minus 75.1 divided by 109 multiplied by 100. So this will be ejection fraction if you calculate it. And fractional shortening, which is 14.7, that can easily be calculated from these two systolic and diastolic interventricular dimension. You will get fractional shortening. So that will be the percent change in the internal dimension of the left ventricle as given in the previous formula. So ejection fraction is calculated over here, and the normal ejection fraction should be 50 to 75. But in the case of systolic dysfunction, what will happen? Reduction in ejection fraction will occur with systolic dysfunction. Reduced ejection fraction is indicative of left ventricular systolic dysfunction. However, the ejection fraction also depends upon ventricular loading, preload and afterload. So we should keep these things in mind as well. And again, I will tell you that ultrasound is a multifactorial modality. We will not rely on just a single parameter. We will see the other parameter as well, which we have discussed and will be discussing. The normal diastolic thickness of the left ventricular wall, that is interventricular septum and left ventricular posterior wall, that should be normally from 6 to 12 millimeter. But if it is less than 6 millimeter, then we can that will be indicative of the stretching up heart muscle. For example, in the case of cardiomyopathy, are scarring due to myocardial infarction. In the case of myocardial infarction, some tissue of the heart are dead, infarcted, and that's why and they will be thin. If the walls are greater than 12 mm, 12 mm in diameter dimension, then that will represent the presence of left ventricular hypertrophy. Reduce systolic thickening of the wall in left ventricular and systolic dysfunction, because normally during systole the wall is either that is interventricular septum or posterior wall, they will thicken as compared to diastolic dimension. So normally the wall should thick in systole, reduce systolic thickening of the wall, indicate the presence of left ventricular systolic dysfunction, either global in the case of cardiomyopathy or regional in the case of myocardial infarction, because in the case of infarction there will be a small segment of cardiac tissue that will be infarcted, so it will result in a regional wall thinning or not complying to systole. And in the case of cardiomyopathy, the entire heart walls muscles are not compliant, and there will be no increase in thickness during systole. In the case of two-dimensional echocardiography, a four-chamber echocardiographic view in the left ventricle systolic dysfunction. So if we use two-dimensional echo, then we will estimate left ventricular volume and in diastole and in systole. So this is done by tracing the left ventricular endocardial border of the of a systolic and diastolic left ventricular frame. We'll take two frames in split screen. In one frame, half of the screen we will have a diastolic frame or picture, and in the other halves will have a systolic frame. From these volume, the ejection fraction is calculated by Simpson method. So how the Simpson method will work? So the already mentioned method of calculating left ventricular volume relies on manual tracing of the ventricular endocardial outline. Alternatively, left ventricular volume can be calculated totally by the computer using Simpson method. So we'll just trace this endocardial border of the left ventricle from the mitral valve annulus septal side to the posterior wall side, and by Simpson method the entire left ventricle will be divided into 20 segments, and the volume of each individual segment is calculated by this method. The left ventricle is divided into 20 sections of equal thickness. The computer takes multiple short axis slice at different level. The volume of each slice is the area multiplied by the thickness. The sum of the volume of all the slices will result in the volume, and this volume will be a little bit more realistic as compared to Tichols equation or cubed equation. So area of the slice will be calculated. For example, the entire ventricle is divided into such 20 segments. So the area of this single slice will be calculated by the formula pi r square. So we will have here not r, but we'll have diameter d. So the d will be calculated, but from d we can have r as well. So if this d is divided by 2, so 2r are equal to 1d. So we'll divide d by 2, and we'll put them in the equation where d is the diameter. Thickness of the slice will be the entire length from here to here, and that length is divided into 20 equal segments. So the entire length divided by 20 will be the thickness of each individual slice thickness. So if we know the area of this slice and thickness of this slice, then we can have the volume of this individual slice as well. So volume of all these slices, this one, this one, this one, each and every slice volume will be calculated individually, and then all the volumes will be added, and we'll get a relatively more realistic volume of the left ventricle. From that left ventricular volume during systole and diastole, we'll be able to calculate the stroke volume very easy, because if we know the left ventricular in diastolic volume and left ventricular in systolic volume, then the difference between these two volume will be the stroke volume. And if you know the heart rate, the number of times the heart pulsate in 1 minute, so that will be heart rate, and cardiac output is calculated for 1 minute. So heart rate multiplied by stroke volume will be equal to cardiac output. So you will calculate cardiac output as well. Doppler echo the cardiac output as an indicator of left ventricular systolic function can be calculated from the peak aortic flow velocity, maximum velocity, Vmax. So this is obtained by Doppler display of aortic outflow from the apical 5-chamber valve. If we get an apical 5-chamber valve, including two atrium, two ventricle, and one chamber will appear like the left ventricular outflow, that will be the aorta. So we'll place our sample volume in the aorta, and we'll get along with the angle correction. This is at most important to be angle should be corrected, right? So we'll get this area under the curve, flow velocity integral, and this flow velocity integral, we analyze it. So the peak velocity which is achieved at this time, so the time from the onset of the systole to the peak flow velocity at the aortic outflow tract, this will be acceleration time, and after that this one will be the deceleration time, right? And the pre-ejection period will be the time just before the acceleration time. So we can have that flow velocity integral with the help of continuous wave Doppler or pulse wave Doppler. So continuous wave Doppler was used for high velocity blood flow, but nowadays with the help of high PRF settings in the power Doppler, there is no more need of continuous wave Doppler for high velocity blood flow, because this pulse wave Doppler can even measure a velocity of 800 to 1000 centimeter per second. In the case of stenotic valve, the velocity could hardly reach to 600 to 800 centimeter per second, and that could easily be encountered with the help of pulse wave Dopplers. There will be no need for continuous wave Doppler, because previously continuous wave Doppler was used because there is no aliasing in the with the use of continuous wave Doppler. But with pulse wave Doppler, we can have aliasing with the spectral waveform. So for that purpose, continuous wave Doppler was used. So pulse wave Doppler provides a better spectral tracing. That's why it will be used. Before going into calculation of the cardiac output, one must know the normal end is of the ventricular ejection. So stroke volume will be 32 to 48 ml per beat per meter square body surface area. But if a patient is of about 2 meter square body surface area, and then and the value, the normal value will be 2 times of 32 to 2 times of 48, because this is for 1 meter square body surface area. So for 2 meter square body surface area, these value will be doubled. And similarly, cardiac output is 2.8 to 4.2 liter per minute. If the patient is of 1 meter square body surface area, but if healthy patient with the greater body surface area, we can calculate these normal values. So there, those will be person-specific normal values. Cardiac output is equal to stroke volume into heart rate. Wow. So stroke volume and heart rate. If you know stroke volume and heart rate, then you will easily calculate the cardiac output. So stroke volume can be calculated by the cross-sectional area of the aorta multiplied by flow velocity integral. The cross-sectional area of aorta can be calculated by the formula, because this is area, cross-sectional area of a rounded structure. So that's why I will use a most pronounced formula, and that is pi r square. So again, we'll use d by 2 instead of r, because we can measure the aortic annular diameter, and that diameter will be divided by 2 to get radius. So the value of pi is 22 by 7. So here we'll put all these values, and d by 2 was put it instead of r. So if 2 is squared, it will become 4, and d was remain squared. So if we calculate all these three values, we will get 0.785 into d square. So now it is too simple. If we calculate the aortic diameter, and the aortic diameter is squared, then that will be multiplied with 0.785, and we'll get a cross-sectional area of the aorta. So normal aortic annular diameter typically ranging from 18 to 33 millimeter. If the aortic annulus is 20 millimeter, for instance, for example, this is 2 centimeter, then the CSA will be equal to 2 multiplied by 0.785, and we'll get cross-sectional area of the aorta is 3.14. And if, for example, just assume if the FVI, flow velocity integral, is 20, then we will multiply 20 with 3.14, and we'll have stroke volume, and that is 62.8 calculated, right? The aortic annulus can be calculated from here. That is too easy. At this region, the annular plane of the aortic valve is a little bit more echogenic. That's why we can measure this diameter more reliably. Flow velocity integral is calculated by computer software. Most of the echo machine as the area under the curve of the aortic outflow velocity spectral display. So we know we don't need to do anything with it. Machine has already calculated it, and it will be labeled as VTI or FVI. VTI mean FVI, flow velocity integral, and VTI, velocity time integral. Both of them are similar. If we place our sample volume at the aortic outflow, we will get such a flow So this area under the curve is VTI, including the peak velocity as well as the time for which the blood was flowing through the aorta. So this all area under the curve that actually represent the FEI or VTI, fluid velocity integral. Using similar calculation, the stroke volume of the right side of the heart can also be obtained using the peak pulmonary flow velocity. So the similar pattern will be taken from the pulmonary artery for the measurement of left ventricular stroke volume. And again, we will take the CSA cross-sectional area of the pulmonary trunk. We'll multiply cross-sectional area of the pulmonary trunk with this flow velocity integral and we'll get a volume. So if you take both the systemic and pulmonary volume, then we'll have a ratio. So therefore, the ratio of the pulmonary flow QP to systemic flow QS, which is the QP to QS ratio, can be calculated to quantify a cardiac shunting. Normally, usually they should be similar, but there is any discrepancy, then we can say there could be to some extent some shunting. For example, if there is some ventricular septal defect, for example, these are the two ventricle, and between these two ventricle, this is a septum, and there is a defect. So blood will flow from the left ventricle to the right ventricle, and that's why the ratio will be disturbed. So this ratio will be calculated for this shunting, right? So some of the pitfalls are there in the left ventricular systolic dysfunction. So left ventricular internal dimension are taken between the endocardial surface of the interventricular septum to the left ventricular posterior wall. An error measurement may occur if a prominent papillary muscle or calcified mitral annulus is mistaken for the endocardial surface. So sometimes, for example, this is a ventricle, both this is a right ventricle, and this is left ventricle. So sometimes there will be papillary muscle from here and here with cardiac tendinae attaching with the mitral leaflets. So sometimes it will be more echogenic and will be difficult to either take this measurement to this region or to this region. So that will become a problem. As differentiating feature, only the left ventricular posterior wall thickness and systole is measured abnormally. Abnormal septal motion, for example, left ventricular bundle branch block makes fractional shortening difficult to measure. Uh, Due to this cardiac tendinae, we can only measure the left ventricular posterior wall thickness during diastole because it is separated from the cardiac tendon of papillary muscle. But when during systole, it come closer to each other, then it become difficult to separate this endocardial margin of the posterior wall from the cardiac tendon. And then apart from that, uh, uh, abnormal septal motion, for example, if there is a left ventricular bundle branch block, then it will make the frictional shortening difficult to measure. And the normal range of left ventricular and diastolic dimension, left ventricular and systolic dimension varies with the number of factor including. For different age, it will they both of them will be different. For different gender, and for height, body habitus, and so on. So this should always be borne in mind that we are measuring these parameters for which type of individual. So measurement of the left ventricular dimension can be unreliable in the presence of abnormal wall motion due to friction, and abnormal septal motion due to left bundle branch block or right volume overload. Reduce left ventricular systolic function is usually but not always associated with increased left ventricular dimension. For instance, a large akinetic segment of the left ventricular wall following myocardial infarction may impair left ventricular systolic function, but left ventricular dimension may be within normal range. So that's why we'll rely on multiple parameters, not only one. An experienced echocardiographer can often give a reasonably good visual assessment of the left ventricular systolic function from parasternal lung axis view without actual measurement. However, this rough assessment may be unreliable for serial evaluation of the left ventricular function when left ventricular volume critically influence the timing of the surgical intervention. There may be intra-observer or even more surprisingly intra-observer variation in the measurement of left ventricular dimension, left ventricular volumes, and therefore in computing of fractional shortening and ejection fraction. Often these are due to variation in the frame frozen for calculation and in the delineation of the endocardial surface. While calculating left ventricular volume, certain geometric assumptions are made about left ventricular shape, which are not always valid, because we assume that left ventricle is oval shaped, particularly in the cubed equation. Particularly in the heart disease, that will not be true. This often occur in regional left ventricular dysfunction. Post infarction, left ventricular remodeling increase left ventricular sphericity and causes alteration of the normal ellipsoid shape of the left ventricle. When assessing left ventricular systolic function, one must allow for effects of volume loading and drug therapy. So fluid overload and antiarrhythmic drug with negative inotropy may further impair left ventricular function. So if some medicine are given to the patient, that must be kept in mind. And the presence of mitral regurgitation ejection fraction may be normal despite reduced contractility of the left ventricle. This is because the left atrium offers less resistance to ejection than does the aorta. Conversely, in the presence of aortic stenosis, ejection fraction may be low despite normal contractility of the left ventricle. This is because the left ventricle has to overcome a high transaortic resistance during ejection. Therefore, after surgery, valve repair or replacement for mitral regurgitation, the ejection fraction fall, and after surgery of the aortic stenosis, the ejection fraction rises. The calculation of cardiac output from peak aortic flow velocity by Doppler is invalid if the aortic valve is regurgitant or stenotic because of increased aortic flow velocity. The measurement of the aortic valve diameter at the aortic annulus is not only difficult, but any inaccuracy is magnified since the d value is squared. Causes of left ventricular systolic dysfunction, so particularly all forms of cardiac disease, ultimately culminate in the left ventricular systolic dysfunction. Prominent causes are coronary artery disease. So in the case of coronary artery disease, either it is single large infarct, multiple small infarct, or triple vessel disease. The infarcted area will be dilated, it will be no longer able to contract. So and this will be systolic dysfunction. Left ventricular pressure overload, so systemic hypertension, ventricular hypertrophy, and the pressure is increased, so that will lead to systolic dysfunction. Aortic valve stenosis, the aortic valve is stenosed, and now the ventricle tries much more to pass blood through that stenotic valve. Left ventricular volume overload. So in the case of mitral regurgitation, the left ventricular will be overwhelmed due to excessive amount of blood. Aortic regurgitation, that can also overload the left ventricle because the blood is pushed by the ventricle through the aorta, but due to the regurgitation, that blood come back towards the left ventricle. Left to right shunting, ventricular septal defect. If there is ventricular septal defect, then there will be left to right shunting, and in that case, there will be systolic dysfunction. And then patent ductus arteriosus, the blood is pushed from the aorta to pulmonary trunk with the ductus arteriosus, and that will lead to shunting. Primary myocardial diseases, for example, acute viral myocarditis, that could be the cause of systolic dysfunction, or dilated cardiomyopathy will also be a cause of the systolic dysfunction. Clinical significance of left ventricular systolic dysfunction, the presence of left ventricular dysfunction and any form of cardiac disease carries an adverse prognostic implication. Patient of coronary artery disease, on one hand, who have left ventricular systolic dysfunction, in addition to wall motion abnormality, have a lower survival rate and poorer outcome after the revascularization procedure like coronary bypass surgery. When a patient of hypertension with left ventricular hypertrophy developed left ventricular systolic dysfunction, it indicates the onset of decompensated stage of the hypertensive heart disease. Volume overload of the left ventricle due to valvular regurgitation of the left-right shunting will ultimately cause a left ventricular systolic dysfunction. Besides being prognostic marker, onset of systolic dysfunction play a crucial role in the timing of the corrective surgery as well. On one hand, if we know about the systolic dysfunction of a patient, we can predict the prognostic the success of the surgery. And secondly, that systolic dysfunction is crucial for the timing and uh, mm, management of the corrective surgery. Presence of left ventricular systolic dysfunction is an important criteria for the diagnosis of dilated cardiomyopathy. Uh, Serial echocardiograms uh, can not only assess the natural history of the disease but also the response of therapy. uh, Subtle abnormalities of systolic function may not be obvious at, at rest, but brought out by exertion or stress testing. So we will use stress test if we find any minor systolic dysfunction. Similarly, only minor systolic dysfunction may be observed after drug treatment of heart failure, which may have caused clinical improvement. Uh, then acute myocarditis is also a cause of the systolic dysfunction. So myocarditis is inflammation of the heart muscle caused by viral coccibe, uh, Coxsackie, bacterial mycoplasm, or parasitic Lyme disease infection. They can be the cause of myocardial myocarditis. The echo features of myocarditis are similar to those of dilated cardiomyopathy with left ventricular systolic and diastolic dysfunction and valvular regurgitation. Abnormal left ventricular wall motion is often global but may be segmental due to patchy inflammation of the myocardium. So, in the case of myocarditis, most of the wall motion abnormality will be global, but sometimes if only some segments are involved in the inflammation, then patchy or segmental wall motion abnormality can also be observed. Differentiating features of the myocarditis. So, the differentiating feature of myocarditis are short history of febrile illness and an ECG showing resting tachycardia with T-wave inversion and ECG. Serial echo showing a rapid improvement of the left ventricular function and regression of mitral regurgitation favor the diagnosis of myocarditis rather than dilated cardiomyopathy. So it was all about the left ventricular systolic dysfunction. We'll discuss the left ventricular diastolic dysfunction in the next session. Thank you very much. See you in the next class.